everyone, and welcome to our show, Let's Talk Sarcoidosis. I'm your host, Dorothea Howard, and alongside of me to my left is my co-host, Mr. Larry Franklin. How are you, Larry?
I'm doing great.
We
Glad to be here.
Great. I'm so glad that you're here. We have a great guest today on our show. We have Mrs. Monica Francis, and she's a physician assistant with aesthetic dermatology, and she's also an adjunct professor with at Howard University. Welcome, Mrs. Francis.
Thank you so much.
Thanks for being here today. We have so many questions that we like to ask you, so we're going to just jump right in and start asking you these questions. Why is sarcoidosis overlooked by practitioners?
Sarcoidosis is quite often overlooked by practitioners, both physicians and physician assistants, because sometimes the lesions of sarcoidosis are nonspecific. There are some lesions that are classic lesions that we see very classically in sarcoidosis, but then there are other lesions that look like other conditions. So, and then also there's another type of sarcoidosis where we see macular papular lesions. Those lesions are chronic and they are asymptomatic. They don't seem to have any symptoms at all, so they're easily overlooked.
Oh, okay. Wow. So what is cutaneous sarcoidosis?
Cutaneous sarcoidosis is the kind of sarcoidosis that affects the skin. So that can be different areas of the body, but it affects the skin.
Oh, wow. All right. Is that something that you notice all the time when you have people at the dermatology practice?
It's not something that we see every day, but we do see often enough.
Wow. And are these classic lesions identified in cutaneous sarcoidosis? And if so, what do they look like?
So there are a few types of classic lesions in cutaneous sarcoidosis. So there are the macular papular lesions, which I mentioned. The macular papular lesions can present initially as a raised bump. That's how the patient sees it, as a raised bump. But after that, and they're kind of purplish looking. We call them violaceous, somewhat purplish looking. But then after time, they become indurated. They become a little flattened, somewhat indented. And then they seem to fade and then coalesce. They kind of mix and group together with other lesions. So that's one type of lesion. We also see plaques. Plaques are raised lesions that are flat-topped, okay, almost like a plane on a surface of land, okay, raised and flat top. We see plaques. Now the plaques can be of various kind of colors. We see them in, so some of the colors are flesh tone, okay, so if it's flesh tone, it might be hard to see, so that's another reason why it may be overlooked in practitioners.
Okay.
Also, so we have flesh tone, also there's a violaceous, there is red lesions, also a yellow to a yellow-brown lesion as well. So we see all of those different colors, and those colors vary in different tones of skin as well.
Oh, I can understand that.
So if it looks like you have whelps, sometimes that could be
It's a possibility.
itself.
Yes, there's a possibility.
Wow.
How often is the skin involved in people who have a diagnosis of sarcoidosis?
In patients who have a documented diagnosis of sarcoidosis, about 20 to 35% of them have cutaneous sarcoidosis, so they have the skin involvement. So that equals up to about a 1/3. So 1/3 of patients who have a diagnosis also have skin involvement.
Jeez, that's quite a bit, though.
Yes, it is.
Yes.
Are there any parts of the skin that are more likely to be affected than others?
Yes, we do see certain classic areas that are most commonly presented. We see areas on the face. So the areas on the face could be around the nose. We call it the nasal ala. So that's around this area here. We see it around the lips, okay? We see it sometimes on the cheek. We call it the malar area on the cheeks. So those parts of the face, occasionally ears, and sometimes fingertips as well.
Jeez.
Yes.
So why is sarcoidosis called the great mimic?
Sarcoidosis presents, as I mentioned, these multiple different ways. We have macular papular lesions, we have plaques. I didn't mention subcutaneous nodules. So these are actually lumps that are underneath the skin, subcutaneous nodules. So patient can come in complaining of lumps on their skin, and we could diagnose it one way, but all the while it can be sarcoidosis. So sarcoidosis presents itself looking like many other different conditions. And some of those conditions could be lupus. We also see another condition called granuloma annulare, a very rare form of TB, which is called cutaneous tuberculosis. Okay, so there's a variety of different conditions that sarcoidosis can look like.
Jeez. What is lupus pernio?
Lupus pernio. So lupus pernio is a kind of sarcoidosis. I know it sounds different because it says lupus, but it's a kind of sarcoidosis that presents in one of the more classic forms. So there's certain parts of the body that are affected. So around the malar area, the nose, and then I believe sometimes I said the cheek area and the fingertips can also be involved. And these areas can be red or violaceous. So it looks like lupus. Lupus has a classic presentation of the cutaneous form of lupus, has a classic presentation of we call it a butterfly rash across the face. So it's like a butterfly that goes across the face, including the cheeks and the nose. So this lupus pernio looks very similar to that. It can look very much like that. And then this particular form of lupus can be scarring. It can lead to fibrosis and even deformities.
Oh my gosh.
This form of sarcoidosis.
Wow.
Yes.
And, you know, with this, how often, I guess the question that I want to ask at this point is the demographic groups, as far as, and we know this, as far as the skin lesions of sarcoidosis, who would more likely get this? And then, you know, when they get these skin lesions, you know, what happens when you live in certain areas? Because they still don't know how you get these. So everybody's living in all these different areas. How is that determined?
Good question. The lupus pernio is most often found in African Americans. So we see that most often in African Americans, and that can be anywhere across the United States. A few Puerto Ricans, but the lupus pernio is most often African Americans. There's another kind that we see, the erythema nodosum. So that's the nodular kind that I talked about. We see that more so in Caucasians and also more so in Puerto Rican patients.
Okay.
I don't know the demographics as far as across the United States, but the kind of people more likely to get the lesions has been well studied.
And I know you talked about macular papular lesions, but what are they?
It's in the dermatology world, we tend not to use the term that often because macular is flat and papular is raised. So we don't like to say macular papular that often, but in this case, there is both. So there's some lesions that are raised, and those may be the purplish ones, and then there's some that are flat, and some of those may have healed and they become indurated and flat, and so those are healed. So then you have this rash of both flat and raised lesions.
It's, you know, they have this unique characteristic about it, and that's why I believe that, you know, it's misdiagnosed.
Very often.
Yeah, because it's the characteristics just mimic so many other things, like you said before. Mary?
You mentioned earlier the term granuloma. What is granuloma?
Granuloma is an inflammatory response that results when macrophages are unable to destroy or fight certain substances, and usually those substances are foreign. So it is a mechanism of the body that we have in order to fight certain substances.
Wow. How is the diagnosis of sarcoidosis made by a dermatologist or a physician assistant?
Excellent question. When a patient comes to an office of dermatology, usually they come in with concerns about a rash. Usually for dermatologists, hair, skin, and nails, but most of the time they're talking about a skin lesion. So if we're able to have an index of suspicion, that means we have these little antennas to say we need to think about sarcoid, we need to think about sarcoidosis. So what we do if we have an idea that this patient may have sarcoidosis is we get permission to perform a biopsy. So a biopsy is done in the office. In the office, it's a very simple in and out procedure. A patient usually leaves with just a Band-Aid and maybe a couple stitches. But we actually take a miniature little piece, a little punch, like about the tip of a pin when you punch a pin, about that much. And the size actually can vary. We punch it out like a miniature hole punch. And we take that piece and we put it into a jar. We send it to the lab. And the lab cuts it up in 1,000 little slivers of pieces, and they use electron microscope to look at it. And what they do is they are able to see something on the scope called non-caseating granulomas. So the non-caseating granulomas is classic. That is how a diagnosis of sarcoidosis is made. So the true answer to the question is it's made through biopsy. We take a biopsy of the skin and we send it to the lab. The lab usually can give a report in less than a week. Most of the time, less than a week, we have a diagnosis.
That's pretty quick, though.
Yeah,
I would just say that's very quick. Yeah. Wow.
What is Hereford's syndrome?
Hereford syndrome. Hereford syndrome is a variant of sarcoidosis, and it involves certain areas of the body. So it can involve the parotid gland, some parotid gland swelling, uveitis, which involves the eye, so inflammation there. Also, a patient can have some facial nerve palsy, so they can actually have some paralysis. So that's Hereford's. Occasionally, they may have some fever as well.
So what you were saying about, just some of the terms that we're using here, sarcoidosis can really manifest itself in a whole lot of different ways. So we need to really pay attention.
Oh, definitely.
Yes, yes. We call it the index of suspicion. So whoever your practitioner is, they need to have an index of suspicion in their mind's eye. So they can just have in the back of their mind sarcoidosis, and they can keep that, so they can have that in their mind, so that they can send patient to a dermatologist or perform a biopsy.
Wow, that's something. Now, what is Lofgren's syndrome?
Lofgren's.
Yes.
So these syndromes can be somewhat rare. We don't see them all the time, especially in dermatology, but it is something that we do see. Now, Lofgren's is the classic presentation of sarcoid with bilateral hilar adenopathy. So what is that? Bilateral means both sides. Adenopathy, we're talking about the lymph nodes that are inflamed, in the lungs. Okay, so you think about sarcoid in the lung. So there's bilateral hilar adenopathy. So the lymph nodes in the center portion of the lungs are inflamed. And then we also see a couple other things. You may see some fever, some arthralgia. The patient feels like their joints and muscles and things are sore. A patient also may complain about those nodules, erythema nodosum, those subcutaneous nodules. Sometimes those nodules are painful at times. A Lofgren syndrome presents with all of these different nuances within that syndrome.
Oh my goodness. I mean, when you think about this disease, you just never realize the impact just of all the things that it can do to you. And I can understand truly how it's misdiagnosed because of all these different symptoms that we get. And how should cutaneous sarcoidosis be treated? So, in the field of dermatology, corticosteroids are very commonly used, and we have different forms for giving corticosteroids. So initially there may be topical corticosteroids. So these are creams and ointments, prescription creams and ointments that have steroid in it. It's corticosteroid. This is stronger than the over-the-counter hydrocortisone. So that's one way, topical cortisones. Also, we use intralesional cortisones. So that's, if you think about it, it's the same kind of cream, similar. It's in a liquid form. Many times it may be mixed with a little bit of lidocaine, and that injection actually goes right to the lesion.
So a
Okay.
patient may be concerned about a lesion on their face, which
Right.
many of the lesions are on the face.
Okay.
And these injections actually go into the lesion in the face.
Wow.
And what that does is it reduces the inflammation. So when
Okay.
the inflammation is reduced, then the lesion can flatten. If it's raised, it can
Right.
flatten, it can soften. If it's been bothering the patient, if it's been inflammatory, if it's been sore, the anti-inflammatory medicine does all of that. Another
Wow.
thing we use in dermatology is oral corticosteroids. So the oral corticosteroids is the prednisone, okay? So we don't
Right.
like to use that for a long time. We don't use that continuously, but if patient is having a flare-up, we give it to them for a short period of time because there are
Okay.
side effects to being on prednisone for
Right.
a long time. People are always wary of the weight gain. People always talk about the
Right.
weight gain
Right.
being on prednisone. So that is one of the issues. And there are also a few other medications that aren't used quite as often, and that would be methotrexate. And then also there's always a Plaquenil. So Plaquenil is usually given for patients who have the systemic sarcoidosis, but
Okay.
occasionally we give it in dermatology as well. So
Wow.
Plaquenil is the hydroxychloroquine.
And we're actually both on prednisone.
Ah.
We're still on prednisone. I mean, you
I
know.
actually have been on prednisone
Oh,
since
wow.
1995.
So that
Really?
Barely.
Well,
Yeah.
most likely then it's probably a very
Right.
low
It
dose.
is.
Just a
Five-
very,
5 milligrams.
Oh, yes.
Yeah.
Very low
Yeah.
dose just to keep the inflammation down. And usually that can be very safe.
And the question that I know everybody, oh my goodness, you know, including us, but everybody wants to know, can sarcoidosis ever resolve on its own?
Sometimes is the answer. Sometimes. So back to the Lofgren syndrome, there's an acute form of sarcoidosis. Acute means it comes very quickly
Right.
and it only lasts for a very short time. So in the Lofgren syndrome, which is the acute form of sarcoidosis, about 80% of patients have resolution in about 2 years. So,
Wow.
but usually it's in the acute form.
Okay.
Many times these patients have the chronic form of sarcoidosis. They have the
Unfortunately,
chronic form. So
yes.
the chronic form lasts for most of the patient's life.
Wow.
So a few patients may have the Lofgrens, and then 80% of them, it will resolve in about 2 years.
Wow. You know, that's the thing. And even with sarcoidosis of the skin, many people have questions about it in general because I've heard by some physicians, and I don't know if Larry's heard the same thing, but sometimes they said it burns out. Is there a such thing of sarcoidosis truly burning itself out? And I know that's similar to can it resolve it on its own, but just in general, is there a true statement? Does it really burn itself out?
Yes, we believe that it
Right.
can. We say there's a term that we say that it's inactive.
Right.
Inactive.
Exactly.
We use that term inactive.
Okay.
So medically speaking, we believe the patient still has sarcoidosis. Some of the lesions may still be in place, whether they're in the lungs or in the
Right.
skin or other places, but it has become inactive.
Okay.
And I think sometimes they use the word remission. It's
Yes.
called
Oh, right.
remission.
Yes.
Yeah.
Being
Yes.
in remission. Yeah. Well, you know, one of the things that I know maybe you can help us out with, if people are, you know, looking for a great dermatology practice, maybe you can share some tips on how do you find the best physician assistant, you know, at a dermatology's office. I mean, I'm sure that people need to know some, you know, some things to do and research what's the best place to go to, because it's hard to really find a good physician assistant. Can you give them any tips on what they should do when they're searching?
Absolutely. Physician assistants actually work with the supervision of a physician. So you can go to the AAPA. That's an organization, and they list all of the physician assistants who are licensed, who have paid dues and they're a part of the organization, and that's across the country. But if you're looking for a dermatologist, first thing you want to look at is someone in your area, of course. In addition to that, you would like a board-certified dermatologist. So this is someone who has taken their board exam and passed the exam. There are some dermatologists that practice and they are not board certified and they do quite well. But we do recommend that patients see a board certified dermatologist, and there is an organization called the American Academy of Dermatology, and most board certified dermatologists are listed with them. Because sarcoidosis affects so many patients of African American descent. We also look at some other organizations that can lead and direct patients to physicians and those practitioners that are familiar and comfortable with treating skin of color. So there are a few organizations that patients can look for, and of course, it escapes me at this moment.
That's okay. That was just something that just came to my mind, and I know people will want to know, so I just thought about it.
It'll come.
You mentioned something, and I know prednisone seems to be, especially with men, seems to be a taboo topic with men. You hear the word prednisone, it's, oh no, I don't want to do that because of the weight gain and the side effects and everything. Is there anything else out there, some alternative medicines that?
Besides the prednisone, yes, but that is one of the few anti-inflammatory medications that are out there. Like we mentioned, the methotrexate. That methotrexate has to be monitored. Your physician or physician assistant has to actually draw some blood work every now and then and monitor how your levels are doing with taking methotrexate. And then also with the Plaquenil, patients before taking Plaquenil, they should have an eye exam and have a blood test as well before taking that. Some, if I may, some men are a little anxious and a little hesitant about taking prednisone because they hear that it's a steroid, and some of them, not you of course, but some of them are concerned about sexual side effects. Now, sexual side effects are not listed. They're not part of the side effects with corticosteroids, with prednisone. Sexual side effects are attached to anabolic steroids. So that's a different kind of steroid. But there are, we've had patients who've come in and have been hesitant to taking them because they attributed steroids with sexual side effects, but that is not the case with prednisone.
Can you just elaborate a little bit on the anabolic, you said
anabolic steroids?
Right, just so people would understand what that is, because we have a few minutes in before we wrap it up, so it's just if they could understand.
Anabolic steroids are the kind of steroids that mostly men, it's not all men, but mostly men take to gain muscle mass. Those are the kind of steroids. So when they take those steroids, there are some sexual side effects. There are also really severe facial and truncal acne. They get acne that is quite severe on the trunk of the body. Sometimes they can get gynecomastia, which is enlargement of the breast in a man.
Really?
Yes. So these are all side effects of taking anabolic steroids.
Wow. Well, you know, this has been a very great conversation, and I know that it's helped many people out there, Mrs. Francis. You know, I can't stress enough the gratitude that we have for you being on the show today.
Thank you so much.
Because we have so many people that have sarcoidosis, and most of the side effects or the initial characteristics that they've seen has been in the skin. So we do thank you. Larry, you want to say anything to Mrs. Francis? Because our time is up, and this has been a great show.
Yes, thank you very much. Very, very enlightening.
Thank you for having me. I enjoyed it.
And we know that you're busy, so we definitely, not only do we, are grateful for you being here, but we sure the viewers that will watch the show. And anyone that will watch the show after it's over will see Mrs. Francis' information. By all means, you can give her a call and call the practice and find out any additional questions that you may have. And we both like to say, we both have sarcoidosis, but sarcoidosis doesn't have us. Until next time, be blessed.